CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Welcome, everybody. For any of you I haven't met, I'm Aggie Black. I'm a research associate at CHÉOS. And I'm thrilled to be introducing my colleague and friend, Dr. Angela Russolillo, who is a nurse and clinician scientist based here at St. Paul's. She is the Director of Mental Health Clinical Research in Psychiatry. She's also an adjunct professor at the Faculty of Health Sciences at SFU and holds a Michael Smith Health Professional Investigator Award. Her academic training includes a research-based MSci and PhD in health sciences from SFU. Her clinical training and experience inform her program of research, which examines health services use and related outcomes among individuals with psychiatric and substance use disorders. Of particular focus are people who experience homelessness and criminal justice involvement. Her research aims to reduce disparities in mental health, substance use, and treatment through health services reform, advocacy, and integration of evidence-based practices. Dr. Russolillo has worked alongside multidisciplinary teams to evaluate supported housing models, examine cross-government data, and develop standards of care for specialized mental health services. Her research program supports several national and international agendas focused on improving healthcare policy and practice for individuals with complex health and social challenges. Welcome, Ange.
Thanks so much, Aggie. I'm super delighted to be here, and that was a lovely introduction. Makes me sound very important, even though I'm not. But I do really enjoy giving talks about work that I'm doing, and it's been quite some time now, given the pandemic, that I've actually had an opportunity to sort of share some ongoing work and talk about sort of some of the things that are at the forefront of my own kind of research interests in the last few years. So I don't have any conflicts to disclose, but I do get paid by Providence Health. That's my main employer, and have affiliations with SFU. And I do have some ongoing research grants, but none of which impede how I interpret the findings. I am kind of presenting some data today that's new and hasn't been shared really broadly, but I'm also trying to create a bit of a narrative that sort of explains where we came from and hopefully where we might be going. And so this is a new format for me, and I'd appreciate any feedback you guys have. But I'm going to talk a little bit about the history of sort of mental health service use, weave in some results that are based here at St. Paul's from a study that we started about 1.5 years ago called the Patient Acuity and Complexity Study. Talk a little bit about implications for policy and practice, which is where I always like to lean after I share some results. And then just discuss a couple of projects that are sort of either actively in progress or hopefully will be in progress if the ethics board approves them, and just sort of where we might be going. So I do come from a clinical background, a nursing background. And as Aggie mentioned, a lot of my work generally has been in the area of health service use. My PhD work, which kind of finalized in 2019, was mostly around population level analysis of methadone treatment and outcomes on various outcomes. So criminal convictions, mortality, hospitalization. And I actually kind of took a real step back from research following the completion of my PhD and decided that I didn't want to do research anymore, that I wanted to go back to clinical practice. And so I ended up working a lot back here at St. Paul's in various roles, and kind of landed in a bit more of a policy-driven role, working with the unions and nurses here at St. Paul's. And then about 1.5 years ago, I said to the director of mental health, who's here today, will you guys take me back? Because I really want to do some research with you guys. And luckily they did. And that landed me kind of where we are today. But it's funny because nobody really cares too much about what kind of research I do whenever they meet me. The 2 questions I always get asked are, "You're super tall, did you play basketball?" And I always have to tell people, I did not play basketball, I played volleyball. So sorry to disappoint you. But I am really good at volleyball. So if you need a ringer at your next rec league, you just let me know. But the other question I often get asked is, "Oh, you work in mental health, you must have some really interesting stories." And they think that I worked in Riverview or in some sort of insane asylum. And they think that I have some kind of flew over the cuckoo's nest version of what working in mental health is. But I don't. Mental health really affects all groups of people across all walks of life, across all stages of their life, and it doesn't look anything like what you see in movies or what you think about. But this is a picture of Riverview, which is what a lot of people think about in BC when they think about mental health treatment. And so I'm going to give you a little bit of a brief history lesson before we kind of launch into some more context here. But the evolution of sort of mental health services in service delivery in Canada, rather, has been marked by sort of three distinct periods. So that moral approach, that was really custodial jail, like people were sent away to never return, and mental illness was considered incurable at that time. And then we sort of shifted over several years to this institutionalization approach, which was really kind of coined, insane asylums. This was like a primitive, sort of restrictive approach to care that was often involved people living out their lives in a particular institution that was removed from communities. And so we saw that with Riverview. And then that sort of institutionalized approach was followed in kind of the 1960s by a policy shift to deinstitutionalization. So we saw shift to community-based care, or what we hoped would be community-based care, and I'll talk about that in a second. And the rationale around that was like we were seeing mass overcrowding in psychiatric hospitals. We were seeing sort of an emergence of pharmacological treatments. So we were able to control symptoms through medications, which we really hadn't been able to do previously in time. And then we were also seeing all the negative long-term impacts on people from being isolated and segregated and living their lives out in these sort of institutions that were really removed from normal community life. So ultimately, we shifted from institutional to community care. And that was really supposed to be marked by an upscaling of communities' mental health supports, counseling, psychologists, access to primary care, affordable housing, all of the things that you would expect to have access to in the communities that we live in. However, that was not the case. And we actually ended up, seeing overwhelmingly that the transition of services from institutional to community was marked by basically massive failure. And we see that every day in what's happening in our province currently. So you don't have to look too far to see that, there's massive mortality rates. The morbidity of people with mental health and substance use disorders is climbing exponentially. And we see the consequences of people with mental health and substance use disorders every day in our communities, and it's overwhelmingly negative. And we've really created a mental health system that's reliant on acute care services. So by deinstitutionalizing and not building up the supports in the community, we've essentially created a system that's reliant on episodic or acute-based services. And I'm going to come back to that in a moment. But what I wanted to just set the tone for was kind of what the impact of mental disorders are worldwide in terms of morbidity, mortality, and cost, because that's really what a lot of the evidence is showing us currently. So we know that mental disorders are prevalent worldwide. 1 in 3 individuals is going to develop a mental disorder during their lifetime. Many of us in this room probably know a person, a friend, a family member, a colleague, or maybe yourself that has at some point suffered from some sort of mental health issue or mental disorder. We know that a lot of folks do respond well to treatment, but that having a mental disorder does result in considerable burden in terms of health loss, experience, stigma, marginalization. And we also know that mental disorders, unfortunately, remain one of the top 10 leading causes of disease burden worldwide, and that's been consistently climbing since the 1990s. So we also know that comorbidity with mental disorders is very pervasive, and we've been learning about sort of how that impacts folks and what happens. And we know that comorbidity is often most common in that first year after the onset of a mental disorder. So there's lots of really interesting work that's coming out of Denmark using large population level data sets, 6 million or more people, looking at comorbidities between mental health disorders and other mental health disorders. And so you can see here by this image that the rate of receiving a diagnosis of a neurotic disorder, so that might include things like anxiety, phobias, OCD, was almost 80 times higher in the first 6 months after receiving a diagnosis of a mood disorder compared to people without a mood disorder. And that's pretty consistent over time, and we see an elevated risk even up to 15 years. So we're seeing a huge impact on people when they're presenting with mental health disorders and subsequent mental health conditions following that. We also know that they're at higher risk than the general population for development of certain medical conditions. So we're seeing greater complexity when it comes to things like circulatory disorders, endocrine disorders, pulmonary, GI, cancers. We're seeing that elevated rate even for things outside of the mental disorder category. So it's just speaking to high levels of disease morbidity in this population. And then we're seeing with that increasing mortality. We're also seeing certain combinations of disorders kind of conferring greater risk. So the more mental disorders you have, kind of the worse outcomes you're going to have. So I really like this article as well. There's some really interesting data manipulation or data visualization rather website associated with this work where you can actually toggle things around to see what different combinations end up being associated with. But overall, if you look at that left side of the image there, that kind of Scantron looking dot section, that's showing you the combinations of disorders. And then on the right side, you're seeing the increased rate of mortality as well as reduction in years of life expectancy. So all disorders, even single disorders, are associated with increased mortality. And there's a reduction in life expectancy ranging from 5 to 17 years based on kind of different combinations of disorders. I mean, this is probably maybe not new news to folks, but it's really compelling when you see it laid out in this way. We're also seeing a dose-response relationship between the number of mental disorders and this sort of new metric for looking at years lived with disability, so the health loss proportion. So you can see as the number of disorders goes from 1 to 4, we're seeing a dose response with respect to that health loss proportion increasing. So this really kind of culminates into a number of things, but it means that there's increasing societal cost per person when we're looking at the number of disorders and kind of the things that are happening to people who have multiple disorders simultaneously. So this is some really interesting work coming out of Denmark, but they've looked at a lot of European countries, and they're looking at the societal cost per patient with respect to different disorder types. Schizophrenia has the highest median world cost at around $13,000 US. If we do some little math for Canada, that's probably about $26,000-ish in terms of societal costs. But you can see that all disorders have a range of different costs depending on countries. In the UK, for example, schizophrenia costs are nearly $90,000 per person. So what are we this is staggering numbers when we're thinking about the rates of people with disorders, the comorbidity levels, the costs that are happening. But we kind of know a little bit less about what's happening in Canada. But I think it's important to sort of frame this in a Canadian context as well. We don't have great data like Denmark does when we're looking at population level data sets and administrative data. That's a whole other tangent, which I won't go on, but for folks who work with health administrative data, you know that it's very difficult to access here in the province and in Canada. And so we don't necessarily have the same platform as other countries do to really make some of these large scale population level estimates. However, I've pulled together a couple of costing quotes here for you just as examples. So $50 billion in 2010 was the estimate for direct, indirect, and intangible costs around mental illness. So direct things are like healthcare use, indirect is like lost productivity, so people not able to work, and then intangibles are things like quality of life. We know that in 2021, the estimate for cost was around $80 billion. So we've seen a huge increase over that time period with respect to costs associated with mental illness. We also know that that healthcare is expensive, hospital stays are expensive. We know that patients are staying in hospitals longer than their illness. And we know that because we are seeing an increase in extended stays or alternate level of care days. So that's when people have come into hospital for a diagnosis or an issue. We've resolved that issue, but we can't discharge them because there's some impediment on the other side of the system that's preventing us from discharging them. So that might be community supports, it might be housing. We also know that every psychiatric unit in the province is over capacity in terms of bed occupancy. So we are always running at 110%. We are never below occupancy. So the system is strained, and we know that for a lot of reasons, but on paper, we should be doing well, no? We've seen a growth in the mental health workforce compared to the population, if we look at what's been happening over time. We've seen major investments in community mental health resources when we compare to hospital services over time. BC has the highest number of psychiatrists in Canada per 100,000 people. We've had multiple attempts at reform for mental health since the 1960s. I mean, there's been reports and, policy level work coming out since 1963 calling for changes to service delivery, integrated care, more community support, de-siloing services, all of these things. And in 2021, the BC government invested $500 million in mental health and substance use services. So on paper, things look like this should be going pretty well. However, in reality, we've been seeing an ongoing declining system. I showed this image earlier, but it's declining because it's not meeting the needs of the people that it's serving. We're spending on services, we're spending on systems, but we're not meeting the needs. And if we were, we wouldn't be seeing the level of mortality, the level of acute service use, the challenges across all layers of the mental health and substance use system, including access to care. And unfortunately, the current context is a little bit bleak. We have an overwhelmed primary care system. Up to 80% of our kind of primary care folks are trying to meet the needs of folks with mental health issues, and 23% of them feel prepared to do so. You don't have to look too far. I don't know if anyone was here a couple of weeks ago, but Dr. Rita McCracken talked about the GP shortage. The province has a GP primary care problem. That's exasperated in folks with mental health and substance use disorders because that's a complex population to help at a primary care level. Couple that with limited access to specialist services, so things like psychiatrists. If we look at a report from CMA in 2019, there's a 24-week wait from GP referral to treatment. That is a staggering number of weeks to wait for someone with a psychiatric issue. It's ridiculous. We also know that we have limited access to community mental health services, so things like counseling, psychologists, housing. 1 in 10 people waited more than 4 months for counseling. And that's probably on the low end of the spectrum. And so all of these things have created a significant shift in the healthcare system, and we're seeing an increased need for acute care services. So that means people are presenting in crisis, psychiatrically unwell to hospitals and emergency departments, and we're doing our best to treat them. But then, unfortunately, once they leave us, they sort of vanish from our sphere of influence, and they go back to the communities that they came from. Couple that with COVID-19, that significantly impacted the way our healthcare system is functioning. And we know that folks with mental health and substance use disorders has been impacted negatively by COVID-19. Pre-existing conditions have gotten worse, and people have developed new conditions over this time because of the isolation, the stress, the fear, all of those things. We also know that we're living through an opioid epidemic. So just add that on to the other things that are happening within the current context of our system. It's created a system that is kind of overwhelmingly reliant on episodic care. So I'm going to go on a small tangent for a moment because I really liked what Dr. Rita McCracken did a few weeks ago talking about the GP shortage, and I've tried to replicate her math here just for impact. So bear with me. BC has a population of about 5.2 million. We know that 1 in 5 people with a mental illness, there's 1 in 5 people in BC with a mental illness, so about 1 million people on average. And we know that there's 747 psychiatrists in BC. Crunch some numbers. If we divide 1 million by 747, we get a ratio of 1 psychiatrist to about 1,300 people with mental illness. We know that psychiatrists spend on average 4 hours per day doing direct patient care. That number's coming from the Canadian Medical Association. So that means they can see 4 patients, new consults. Psychiatry tends to have longer consults than GPs, for example. So an average assessment would probably be about an hour for a new patient. So that's 4 patients a day. We know that it would take them 334 days to see all those people if we lined up everyone from 1 to 1,338. But there's only 250 working days in a year. So we're going to do a little bit of math and multiply that by 12 to give us, they can see a new patient every 16 months. So essentially there's a 16-month wait list for psychiatry services in the province if we do the math, and we expect that every patient needs to be seen. And I would argue that probably every patient would benefit from a psychiatry consult. Maybe they don't all need them, but that's sort of what we're working with. So there's a huge strain on the system. We've created a system that doesn't allow for services to be available, and it's to no fault of the folks that are doing the work. I am a clinician myself, and I know that we're working really hard, and I know that we're strained and we're worried about the fact that we can't make a bigger impact. And I know that all mental health clinicians, whether you're a psychiatrist, a psychologist, a peer worker, are doing the best that we can, but we've been kind of set up in a way that doesn't allow us to do our best work. We've really, as I said earlier, created this sort of episodic-based care. There's a lack of continuity, a lack of satisfaction, quite frankly, and just an inefficient, siloed, fragmented system. This radar model sort of kind of speaks to that episodic piece. Patient shows up, they're in our radar, we treat them, we see them, we discharge them, we send them home, and they vanish from our radar. We have no understanding of what's happening to them. And when they vanish from our system, we could have been doing the best care possible. But if we send people back to the places in which they came from that made them sick, then we could have the best services in the world, but it's not going to make much impact. Many of you are probably really familiar with some of these images. The one on the right, the tents, is from the downtown east side. I personally live in Strathcona, so I see this image a lot. And it's one that many people have seen and probably become somewhat desensitized to. But when you look at it in this way, and the fact that it doesn't really make much sense to provide excellent care in hospitals if we're just going to return people to conditions that made them sick in the first place. And this concept of, social determinants of health, things that are affecting our health, isn't new. We've been hearing this for a really, really long time. We know that social determinants of health account for between 30 to 55% of health outcomes, but we do not factor that in enough when we're thinking about how we're building health systems and providing care. When we look at sort of what's happening in our own acute health service system, we know that we're seeing lots of people in our EDs. People are coming back multiple times. We know that majority are presenting with co-occurring disorders. We've actually seen an increase in the rate of discharges for mental health and substance use within BC when we compare it to the Canadian rate. And we're also seeing increases in 30-day, readmission for mental illness in BC. We're also seeing there's an effect in terms of the economic gradient, so poor and rich people and what those differences are. But really some of the things that we don't focus on enough are the fact that this is a very complex population, and complexity is something that I've been tackling within my own understanding of this work and in trying to unpack in my own program of research. And I've been trying to use the term multi-morbidity to sort of encapsulate some of the things that are really happening for folks. So we know that treatment is complex, and we know typically we've categorized people with mental health and substance use disorders as having comorbidities or co-occurring disorders, simply meaning they have one mental health diagnosis and one substance use diagnosis. But really the picture is much broader than that. We know that multimorbidity is the term that's typically been used in geriatric populations to describe sort of multiple diseases across different systems of the body. And that's pretty typical of what we see in folks with mental health and substance use disorders. Single diagnosis is the exception now. We do not really ever see anyone with just depression. And if we did, that's the simplest, treatment option and the simplest path forward in terms of evidence-based practice. But what we see is really medically complex people. We see people with violent histories, with criminal histories, with, severe sort of challenges in their own social lives and settings, homelessness, abuse, trauma histories. So the picture is not straightforward, and tackling complexity or multimorbidity in this sense is really challenging. And trying to sort of measure it and capture it in a way that is meaningful at both like a policy level and a clinical level is very difficult. I sat on a committee or I worked with a provincial committee kind of supporting some policy level discussions around nursing and how we were going to be allocating workload for nurses. And the one thing we were all trying to do was define complexity at a provincial level, patient complexity. And I'll tell you, it was an impossible task. We spent hours, days, weekends, nights trying to come up with a standardized template for complexity for people who are accessing hospital-based services, and it was impossible. And it has remained very challenging for lots of reasons, some of which I think are the way in which we collect data. And again, I won't go on that tangent, but we don't do a great job at collecting the demographic data, things that are directly linked to social determinants of health. I can speak from my own experience. We have an electronic health record, but if I went to go pull data from that right now, my data would not be that great quality. So there's a problem there, but that's for another day, or talk to me offline. We do know, we do often ask ourselves though, kind of what do we need to do to sort of make change in the health system? And we know certain things really drive changes. We saw COVID be a big change. That was a big social change. We've seen changes when there's been surges of money or influence. But we've really focused, and I think sort of some of the challenges that we really focus, we shouldn't really be asking ourselves what pushes the need to change, but we should really be asking ourselves, what would it take for this problem never to happen again? So those are very different questions. And one of them is way more downstream and one of them is much more upstream. And many of you are probably familiar with sort of the upstream solutions and the, you know, throwing people into the river, pulling them out of the river, that whole analogy. But I think thinking about this question, what would it take for this problem to never happen again, is very different than the question of what drives healthcare change. And we should really be thinking about those things as we're making decisions as clinicians, but also as researchers. And so this question has really started to sort of drive my own thinking about work that I'm doing and the ways in which I want to, you know, understand what's happening and influence change at the practice, you know, policy level. But we've really been stuck in this sort of downstream trend for a long time. And I think that there's actually a lot more pragmatic ways to go about making changes, because it can be really daunting to think about, you know, that bigger question, you know, what would make this never happen again? But on a smaller scale, we can think about what's happening in our own local institutions and what's happening in the patients that I'm seeing and the people that are presenting to where I'm working. And, you know, it could be as simple as, you know, using some really basic epidemiological data to come up with some really straightforward solutions that I can implement very quickly. And so as a clinician who works in a health system, I do have sort of an opportunity to be more impactful with the work that I'm doing, because I can take what I find from a research perspective and create change very quickly in the spaces that I work. And so I'm hoping to be able to talk a little bit about some of the work that I've been doing and how I'm trying to make some of those, hopefully, smaller changes that will eventually have larger upstream impact. So thank you for listening to my tirade, and I'll get off my soapbox now and talk a little bit more about some of the actual research work that I'm doing. But I think it's really important to understand some of that context, because it does really inform what I do anyways, and I think it's important. So the patient acuity and complexity study, PAC study for short, was sort of came out of just some initial thoughts that we were having when we really started, when I personally really started in this role with psychiatry. We've all been really interested in sort of the patients we're serving. Who do we see? Why are they coming to us? We wanted to know more about their characteristics. And so we just decided to basically create this sort of retrospective cohort of patients who we've seen here at St. Paul's who've accessed acute mental health services. And that's really was driven just kind of out of some pure interest, but also because we know that patient complexity is increasing worldwide, and we have very little understanding of what that means. We also know that measuring complexity is super challenging. I talked about that already. There's no clear definition. And we know that various factors like age, illness severity, poverty, you know, multiple conditions all influence complexity, and they're all related to cost. And then we've just been sort of really keen in psychiatry anyways to understand this because of the phenomenon of basically everyone has multiple disorders now, everyone, and multiple health issues and multiple social issues. And we just don't know enough about that. So we kind of collected data from January 2016 to December 2020, electronic medical record data, as well as discharge abstract data. It's the best we could get. So it's definitely identified some gaps in areas that we need to do better data collection, but I think it is helpful in this sort of beginning conversation. So we were interested in things like temporal trends and rates of admission, kind of clinical demographic information, and also associations between length of stay, which is kind of a primary predictor of kind of a performance indicator, quality indicator. We use that all the time in healthcare to talk about what's happening in terms of service use and things, and diagnosis and other things that were influencing that. So this work was done by a team of folks, so myself as well as other members of the Department of Psychiatry, and the analysis was conducted by one of the statisticians at CHÉOS. So this cohort was predominantly male, age 39. Schizophrenia and psychotic-related disorders are kind of the most disorders we see commonly with respect to admission, followed by mood disorders and then substance use disorders, and so on and so forth. So schizophrenia and psychotic-related disorders are kind of like the largest proportion of folks that we see. And I bet if I asked you earlier, and I meant to do this, but I forgot, who do you think we see the most here at St. Paul's? It probably would not have been people with schizophrenia. I would have probably guessed you would have said something like depression or anxiety, for example. But in fact, we see folks with schizophrenia and psychotic-related disorders the most. And so that's a very challenging disorder. Often folks have severe treatment resistant and spend a lot of their lives kind of in and out of episodes of psychosis, coupled with managing several other sort of like clinically significant things that are happening for them around that type of disorder. So it's very challenging for folks, and it can mean a lot of exposure to hospital-based care. So we were also interested in looking at this sort of temporal trend and if we've seen any changes over time with respect to diagnosis. So things were pretty stable, with the exception of we've seen an increase in the rate of admissions for mood and affective disorders over time, and we've seen a decrease in the rate of substance-related disorders. There might be a few reasons for that. We know that there's been an ongoing opioid epidemic, so the mortality rate has increased over that time period as well. But interesting, we didn't know this before, and it's interesting to think about the fact that we've seen increases or decreases at all with respect to disorder types. It tells us a little bit about what's going on for folks in terms of who we're seeing. We looked again at whether or not there was any temporal trends across disorder types and as well as length of stay, and we didn't see any sort of temporal trends there, but this gives you kind of a unique picture of each disorder type, length of stay, and by year. We also know that hospital length of stay increases as age increases, and we also know that female patients have longer lengths of stay than male patients. When we looked more specifically at different disorder types and length of stay, we saw that people with schizophrenia and psychotic-related disorders had longer lengths of stay than people without those disorders. We also can see that there's patients with substance-related disorders, anxiety disorders have shorter lengths of stay than people without those disorders. And there's some other trends there that you can make out, or I'm happy to talk to offline. But essentially, it's very interesting from my perspective, and I think from other clinicians' perspective, to see the breakdown of folks with respect to disorder type, length of stay. You can see there's a huge amount of outliers at the top of the figure there with respect to some people saying, hundreds of days. That is significant in terms of what we're talking about in terms of health resources, but also, again, speaks to the fact that we're seeing folks stay in hospital much longer, often for reasons that are unrelated to their diagnosis. So we also ran a multivariable negative binomial regression, which basically has given us sort of a little bit more information about the association between length of stay and disorder types. So substance-related disorders, anxiety-related disorders, adult personality and behavior disorders are all significantly negatively associated to length of stay. So if we look at that rate ratio, I've highlighted a couple of them there. Essentially, that if we look at the ratio of length of stay between patients with substance-related disorders and without substance-related disorders, you can see it's 0.33. So that means that the length of stay in patients with substance-related disorders is 67% less than for patients without substance-related disorders. And that principle applies to the other rate ratios there. But that's very interesting information and speaks specifically to the type of services that are being provided. There's lots of discussion about length of stay because it is one of those performance metrics, quality metrics. And I think we've kind of come to think of it as a way to measure kind of success or quality within the health system, but we've never really understood it when we looked at it by disorder type or how that might impact care outcomes. So kind of all of these findings together, I think that it's really interesting from an individual sort of level perspective to look at what this means in terms of the health system. I think this information could be very useful to optimize service planning and minimize the negative health outcomes for folks. And I think that it really leads us to thinking about more person-centered versus system-centered care, because this is not a homogeneous group. The heterogeneity across all of this is super prominent, and we've lumped people into sort of broad categories that really don't explain what's happening. And so this sort of small bucket of work, while I wish it was a bit more comprehensive, speaks to some of those differences in a meaningful way that I can take back to a clinical area and say like, hey, we could think about doing this because of what we know about who we're seeing here and over this time period. So that for me, that's kind of the important piece. There's many other kind of, avenues we could go down with this information, but I think it's really helpful, and it's work that's important. And I think it's work that will further help us unpack this idea of complexity in the long term. But I'm open to hearing other people's thoughts about all of this. I'd love to hear other folks' impressions of what they think these findings can speak to. So just looking at the time, the other bucket of work that sort of came out of this same cohort of data was we looked at factors that were impacting readmission. And so we actually know that about 17% of that cohort is homeless at index admission. And that's a pretty high percentage of folks. I've done other work in homelessness before, but we've never looked at it with respect to our population here at St. Paul's. And so, we know mental illness and addiction are really common. They result in repeated hospitalizations. We know that they're more prevalent among people who are homeless for many reasons. And we know that from the literature that there's a really wide variation in the level of risk for readmission and kind of variation in the level of follow-up. So there's some studies that are focused really close to that discharge period, less than 7 days, other studies that only follow people for short periods of time. So we wanted to sort of take this information we had and sort of design a study that could look at the impact of readmission rates with respect to homelessness in this population. So we were really asking the question, is homelessness associated with risk for 30-day and 90-day psychiatric hospital readmission? And we used a Cox regression model to do so. This work was done in collaboration with some colleagues from SFU, and it's currently under review. So I would ask that nobody share this information broadly on their social media channels because it's not supposed to be broadly shared beyond scientific meetings. So the cohort was very similar. High proportion of mental illness, mean length of stay was 19 days, 29% had at least one readmission in that time period, and 17.5% were homeless at the index admission. So what we found was that there's a 2 times essentially greater risk for people who are homeless to be readmitted within 30 days. And that risk sort of stays significant up until 1 year after discharge. So not having a house leads to frequent returns to hospital in the immediate period and in the long-term period. And so Again, this is not new to clinicians that have been working here at St. Paul's. I've heard from physicians that we work with that this is basically validating their experience or anecdotal experience about what's happening. And it's really just reinforcing the need that homelessness at discharge is impacting our healthcare system in a number of ways, but that we really need to be addressing the non-medical supports. You know, housing is a modifiable and protective factor against readmission. What are we doing about housing? I mean, it's impossible in Vancouver to live on an income less than probably, $500,000 because it's so expensive. So what about the rest of the folks who don't have that level of support, or have families who have bought them a house, or had families who have sent them for good education? So at the policy level, there's a lot of things that need to be done, but permanent supportive housing is really critical to health for a number of reasons, and it's showing, and we're seeing that locally here when we're looking at the populations that we're serving. So one of the things that I've done with this information,
Code white, Providence, 7 Delta.
I'll just wait for that.
Providence, 7 Delta.
So one of the things that I've done with this information, as a nurse by background, I've developed many evidence-based guidelines that used to be the bulk of the work that I did. So I've taken this and now I'm creating a care of homelessness and vulnerably housed guideline for psychiatry, which essentially is going to support our nurses and physicians in identifying homelessness, asking the right questions, documenting it correctly in our system so we have that data and we can look back on it, and then providing them with the supports and services to go out into the community and hopefully have a bit of a better outcome. Right now, we have no standard care for people who are homeless, nothing standardized. So, this is my small effort at making some changes. My longer term efforts are centered around a couple of things that I'm currently trying to get off the ground. So I talked a little bit about, I think I talked earlier about some of my Michael Smith work, which is essentially funded, and I'm currently going through some of the ethics hurdles, but basically creating a prospective cohort study for folks who have multimorbidity in that psychiatric substance using population, doing some baseline assessments around quality of life, disease burden, those sorts of things, and then doing linked administrative data to follow people over time and understand their interactions with the healthcare system. So that's my larger project over the next 5 years. I've also got a little bit of funding from Providence Research and decided to put together a bit of a Delphi study to create sort of a framework of care for folks with mental health, substance use, and other related disorders. That's really going to be informed by this expert panel of folks who includes patients, family members, researchers, and health services clinicians to really sort of hopefully shape a framework of care that's going to meet the needs of folks who are using it, but that also is sort of grounded in some evidence-based approaches. So that's actually currently actively in the data collection phase. We just launched our survey 1 of 3 last week. So I look forward to maybe sharing some of those results at a later time. And I just really appreciate you listening to my long-winded rant about mental health and substance use services. And I look forward to hearing from all of you. And if you have any questions, I'd be more than happy to answer them.